to Surgeon's Log 2021, Case Archives of the Skull Base and Beyond, a webinar presented by the North American Skull Base Society in association with Global Brain Surgery Initiative. I'm your host, Dr. Walter Jean. If you've enjoyed this and other episodes, don't forget to click the subscribe button on our YouTube channel so that you don't miss any future episodes. For now, let's get ready for yet another exciting and entertaining episode of Surgeon's Log 2021. Dr. Raza is going to be our presenting surgeon today. He, of course, is vice chairman and a skull-based surgeon at MD Anderson Cancer Center. And for our esteemed guest today, our honored guest today is Professor Dan Fliss, who is chairman of otolaryngology at Tel Aviv University, a senior member of the high society of skull-based surgery, shall we say, and a frequenter of the North American skull-based meetings. And I remember being a younger, attending, I guess, listening to Professor Fliss's talks at the NASBS. And it's a true honor to have him as the discussant today for our case. On the hot seat is Todd Hollon, who is apparently not a fellow anymore. Things change, He was the fellow at the University of Utah for neurosurgery, but now is a early career neurosurgeon at the University of Michigan, where I take it that he trained too, right? Is that right, Todd?
That's right.
But nevertheless, he will serve as the hot seat, quote, trainee, unquote, for the purposes of this particular episode. Without further ado, let's get going. This episode is called Lockjaw. It's not going to be a mystery as to why it is from here. You have, Todd, a 17-year-old boy. This is an office visit, 6 months history of right-sided symptoms as following. There is face pain in the V3 distribution, otalgia, muffled hearing, and trismus, thus lockjaw. On exam, the V3 neuropathy is verified. I guess that's numbness. The facial nerve function is normal. The hearing is as you see there. The Weber test lateralizes to the right and the René is negative. There is an unusual spot in the ear canal, which is noted on the right there. I hope everybody can see that. And the rest only shows the limited jaw opening. So from here, any thoughts just in very early going?
Yeah, I mean, the limited jaw opening is concerning. I worry about the potential involvement of the glenoid fossa. It's something that's clearly involving the petrous portion of the temporal bone, being that has V3 symptoms with the hearing assessment, as well as the obvious physical exam findings in the ear canal. So yeah, there is concerning that there could be a mass lesion, something displacing the glenoid fossa, the normal anatomy in that location.
All right, so let's move on. There you go. Tell us what you think.
Yeah, so we're looking
first impressions.
Yeah, so this is a non-contrasted CT axial cut. There's an expansile boning lesion in the right temporal bone involving the middle fossa as well. It's anteriorly located in the middle fossa. It's sort of a mixed sclerotic appearance. And it looks like it's anterior to most of the inner ear structures, cochlea, and also anterior to what looks to be the carotid canal foramen mastorum.
All right, let me give you that.
Yeah, so this is a axial cut MRI. Looks like both contrasted two left-sided scans, and then a T2 on the right. So yeah, large, heterogeneously, looks like mostly peripherally enhancing lesion. Looks consistent with the CT scan.
Okay, so that's fine.
Yeah,
that's good. Okay, so this slide always follows the initial viewings. What is this? What is next? Do we really know what it is? Can we know what it is yet?
Yeah, I think tough case. I think the differential is challenging. I mean, I think the bony appearance is probably most helpful. I think it could be an intrinsic bone tumor, it's osteosarcoma, giant cell tumor, possibly chondrosarcoma. I think other things could be cholesteatoma or cholesterol granuloma, even though I think the bony changes look a little inconsistent with that. Certainly possible and on the differential.
I think those would be really lower down now, wouldn't it?
Yeah.
So in terms of what is next, are we ready just to hack it out? Can we move on with the webinar?
Yeah, I think it's challenging.
Yeah, because you gave me a long list of diagnoses, it might be worth doing something before we move too fast, right?
Right. Yeah, I mean, I wonder about doing something, some more advanced imaging, functional imaging, like a PET scan or something that may help us determine potentially the malignancy of the tumor. Again, the utility.
That's a great thought. What else can you do to really help that with more certainty?
Yeah, potentially we could do a biopsy, but
that's a great idea. I mean, it seems to be readily accessible for that at least, right?
Yeah, I think so.
So would you go through the maxillary sinus, or would you go through something else?
Well, I think the lesion we could view it through the external ear canal. I'd have to talk to my neurotology colleagues about whether that's a reasonable thing to do. It looks like it is accessible through the maxillary sinus, so I think that's also an option. I think both are reasonable.
But what would you think the cleanest path is to biopsy?
Yeah, I think I'd go through the maxillary sinus.
Okay.
Yeah.
All right. So, but biopsy nonetheless, huh? Okay.
Yes.
So you can see the needle path, just straight lateral. I think that's very reasonable. Now, I don't know whether the parotid's in the way or whatnot. It's kind of hard to see on the levels. You know, we just have one or two slices, but there you see what they chose. What do you think about the histology?
Yeah, I think given the CT findings and the MR, I do think that that's a reasonable diagnosis. It makes sense to me. So yeah.
So now, again, back to this slide. So now that you have the chondrosarc, I mean, do we need more diagnostic assessment? Do we need more, a lot of times on this webinar, at least, everybody asks for angios. I'm not entirely positive how angios would benefit for this particular case, but is there something else we need to do given a sarcoma, right? Chondrosarc.
Sure. I mean, I think it's reasonable doing a skeletal survey. I wouldn't necessarily think that any vascular imaging like an angiogram would be essential. It doesn't look like it involves the petrous portion of the ICA.
Right. So tell the younger group of the audience what does a skeletal survey mean at least to you? What do you mean by that?
What does what mean? Sorry.
You said skeletal survey. What are you actually going to order?
Yeah, so I think you can just order X-rays of the long bones just to see if there's any other locations of any other chondrosarcomas. That would. All right,
we're the United States. We like to waste money.
But yeah, I don't think any vascular imaging is necessary. I would want to look through the rest of the scan just to make sure there's no large vessel involvement.
Come on, Todd. This is not University of Michigan. Hey, this is MD Anderson here. Okay, just spend some money here.
Yeah. We need all the studies, image everything. Yeah.
Well, how about PET CT?
Sure.
So I think that's very reasonable, by the way, because it gives you not only just the bone, but it also gives you more, right? Here you go. You got a sub-centimeter pulmonary nodule, but there's no uptake though. But fortunately for this 17-year-old boy, there is no evidence of systemic metastasis at this point. All right, now we're getting to the high dollar value questions now. Anatomical and assessments. When you look at this thing, where are your eyes drawn to? What are you? And again, try to think of it as telling the junior and mid-level residents what is your eye focused on, because it influences what you do?
Right. So with chondrosarcoma, I do think that surgical resection is the best option, and I do think that
Oh,
just
we'll get that. We'll get to that part. But just where for consideration of surgery, what are
yeah,
you looking at?
yeah. So I'm looking at the ICA, and I'm looking at the ear, the inner ear. I'm looking at trying to determine, if we're going to attempt a surgical resection, what structures are we likely to harm, and trying to get the most amount of tumor out, rather than looking at the tumor itself.
So you're looking at the artery,
You
you're
got it.
looking at the carotid, and what else?
Yeah, so I'm looking at the cochlea and the inner ear, and then it doesn't. Yep. Yeah.
Yeah. So there you go. I mean, you were, you sure you haven't talked to Shaan about this case beforehand?
No.
These are his arrows, and you just mentioned what he wanted you to focus on
Yeah,
as
sure.
well. So how does that, okay, so you do see the relationship between the cochlear and the carotid and this thing. Now that you see the actual relationship, what do you think about potential resection? What are the implications for closure? What, you know, think out
Yeah,
loud for us.
absolutely. Yeah. So, trying to preserve the cochlea and obviously avoid large vessel injury is the goal, combined with the other edges of the spectrum, which is trying to remove as much tumor as possible, given the patient's age and the pathology. So my surgical planning would be such that I would try to, remove as much of the tumor as possible while preserving both of those two things. That's sort of the starting point.
Well,
Uh,
is a gross total possible given what you actually see of the relationship?
yeah, I don't think that it's going to be a complete total, like an en bloc resection. I don't think that that is an option. But I do think trying to do maximal safe resection in this case is the best surgical goal.
Now, you did tell me early on that this involves the middle fossa. Do you think it involves the dura?
I do think that there probably is dural involvement, especially it's a little hard to tell from this cup, but yes, I do think it involves the dura and the um, with the V3 involvement. It's I think that.
All right. So that said, are you going to take the dura?
I think you'd have to see what it looks like intraoperatively, but yes, I think if it's safe to do so, I would.
And if you do that, then what? Okay, so if you do take the dura and you do a complete resection, you need to plan for something else, right?
Right. So risk for CSF leak absolutely is an issue in this case. Closure is always, if you're going to resect a large tumor, there's always going to be dead space, and then if you're going to resect the dura, there's always a risk for CSF leak, CSF either rhinorrhea or otorrhea. So I would worry about that in terms of closure.
All right, let's worry about it a little bit more than that. What do you mean by worry about that? There's worrying about, okay, I'll lose a couple of minutes of sleep, and worrying in your recruiting army. What along the spectrum are you worried? How worried are you?
I'd say right at the top. So on the scale of 1 to 10,
So
8 or
what
9.
what does that mean in real life though? You have to.
Yeah, so I think you need to prepare at the very least for a generous fat graft. That needs to be something that you're ready for at the time of surgery. I think that would be the minimal amount. I think it's a little hard to tell from the MRI, but there is what appears to be potentially skin involvement in the external ear canal. So whether we need a flap or those sorts of things. Again, I would default to my ENT colleagues about that, but I think that it's something that would need to be discussed prior to the operation.
All right, so maybe more than ENT, huh?
Yeah, exactly.
Like who?
I think either plastic surgery is
Okay.
a consideration.
Well, any alternatives here? Are we can we zap this thing? Can we poison this thing before or after? What about alternatives? Anything?
Um, not that I know of. I mean, I know with chondrosarcomas, I mean, the preferred and the best option is surgery. I think with the amount of mass effect, um, I think the patient does warrant surgery. So that would be my recommendation. As far as I know, there isn't any specific chemotherapies that would be.
And there's no pre-op treatment like
No, there's
embolization or
nothing
any kind of treatment that
neoadjuvant.
you're going to get, right? All
No.
right. I think that the involvement of the plastic scene may be particularly important if you're, especially if you're thinking about downstream radiation too, right? Because you that's going to cause an issue as well, at least a related issue. All right, fine. You already said this. Let's reverbalize it. Can you just briefly re-summarize this?
Yeah, absolutely. I think at the outset, knowing having the tissue diagnosis is really helpful for surgical planning. And I think with mesenchymal chondrosarc, again, safe maximal resection ought to be the goal at the outset. So,
Fine.
the planning
All
should
right.
proceed from that.
$50,000 question now. What are your options for your approach?
Yeah, this is challenging. I think starting with a lateral approach would be kind of the best first option in my mind. The tumor is laterally located, so I think planning an approach for that would be best. It looks like it's low in the middle fossa, so I think doing something like a orbitozygomatic would be an option. We may need to get even lower than that. Skeletonizing the facial nerve is likely going to be required in order to get the inferior portion of the tumor. Having said all that, I think an endoscopic transmaxillary approach may also be needed to get the anterior-most portion.
So you want to do a multi-directional, so like a Caldwell lock or what?
Yeah, I think that's. I think that it may need to be done that way. I worry about the anterior-most and the wall of the maxillary sinus.
Interesting. Yeah. Okay, so possibly multi-directional. What about the ear canal? Do you have to close it?
Yeah. Again, I think just having the one picture, it does worry me that there could be skin involvement there. And I think there would have to be a judgment call at the time of surgery, whether to close the ear canal or not. And also whether you feel like you are confident in your CSF repair.
All right, final, this is the $1 million question, and then you get the rest. What are you going to do?
Yeah, so I think I would start lateral with obviously ENT, and I would definitely want a plastic surgery, consultation to see what they thought was best about the approach, and then basically decide on doing it staged with a transmaxillary endoscopic approach, whether depending on how the initial lateral approach went. That would be my decision.
Okay, so staged, multi-directional. Okay, excellent, Todd. Thank you. You can sit back and relax now. It's Shaan's turn to now present. Again, Dr. Shaan Raza, Vice Chair of Neurosurgery, MD Anderson Cancer Center. Thank you for the case. And you can go ahead and I'll run your slides for you.
Sure. First of all, Walter, thank you so much for having me on this session. As we were talking earlier, since you started this, I've watched every single episode religiously. And
oh my God, we got a groupie.
We got a groupie. Yeah, exactly. If you start selling T-shirts, I'll buy them. So. Though I think you should start giving out an award for whoever has the best guess in terms of the diagnosis before the session, given the titles that you have. And then Todd, great job with the case. It's tough going through a complicated case on the fly in a short amount of time. So in terms of how I thought about this case, if you go to the next slide, please, Walter, thank you. So the first step here is really establishing a diagnosis. The diagnosis really dictates everything in terms of the indications for surgery, the goals for surgery, and what comes before or after surgery with regards to chemoradiation therapy. And, you can always certainly develop a differential diagnosis based on the location of the lesion, within the anterolateral skull base, the most common malignancies that we see. Certainly the primary infratemporal fossa malignancies would include, for example, the soft tissue sarcomas. The malignancies that secondarily involve the infratemporal fossa would include, for example, bony sarcomas, as you mentioned, some of them, Todd, chondrosarc, osteosarc, and then certainly if you're dealing with the head and neck population, skin cancers, and, parotid malignancies. But of course, that's all guesswork based on an MRI scan. And, as surgeons, whenever we see a large invasive tumor, the tendency is to jump into surgery. But with rare exception, unless there is brainstem compression with hydrocephalus, always get a biopsy ahead of time. Because that really it's sort of like playing chess. You can plan your moves ahead of time. And here, we did a CT guided biopsy that was just done right in front of the mandibular condyle and inferior to the zygomatic arch, so above the parotid gland. And that established a diagnosis of a chondrosarcoma. Now, when we hear the term chondrosarcoma, I think instinctively we think of an indolent, low-grade disease process. But as a matter of fact, chondrosarcomas span the spectrum with regards to where they arise in the skull base anatomically, but also with regards to biologic behavior. And histologically, chondrosarcomas are broken down into 3 different subtypes: conventional, mesenchymal, and dedifferentiated. The conventional subtype is broken down into 3 different grades based on histology. And the conventional chondrosarcomas, statistically speaking, are the most common in the skull base. Those are the ones that arise at the synchondroses. For example, if you think of a petroclavicle chondrosarcoma, they tend to be conventional chondrosarcomas. On the other hand, the mesenchymal and dedifferentiated chondrosarcomas tend to be anatomically much more extensive processes like the one you see here, and have much poorer outcomes. So for example, when we looked at our own experience several years ago, the mesenchymal and dedifferentiated chondrosarcomas have a much lower tumor control rates and much lower survival. And while the conventional chondrosarcomas are at risk for local recurrence, the mesenchymal chondrosarcomas, these patients not only die because of local recurrence, but also because of systemic disease spread. And so that was the rationale for also staging the patient as soon as you establish a diagnosis, because you're not going to take a patient to surgery who has metastases at the time of surgery. Next slide, please. So in terms of how does histology factor into decision-making, right? So as I mentioned, the conventional chondrosarcomas, when they're at risk, they're only at risk for local recurrence. And so in those patients, the goal of therapy is local control. And that's why we rely on local therapies such as surgery with or without radiation therapy, depending on histologic grade and extent of resection. And this is sort of our mindset at MD Anderson. With the mesenchymal chondrosarcomas, because of their poor outcomes, their risk of systemic disease spread, there is data not only in the neurosurgical literature in our own practice, but really from the orthopedic and spinal oncology literature to use neoadjuvant chemotherapy. And there's several reasons to use induction chemotherapy, even though you're going to go to surgery. And one reason to use induction chemotherapy is that for an anatomically extensive malignancy like this, with neoadjuvant chemotherapy, there is the opportunity to anatomically downgrade that tumor so that it can facilitate your ability to get negative margins throughout the case. The other rationale for using neoadjuvant chemotherapy, even though you can hit the home run and get negative margins, is that by giving that patient chemotherapy before surgery, you have the opportunity to study the surgical specimen with pathology and determine the degree of necrosis in relation to as a result of chemotherapy. And then post-operatively, is that a good chemotherapy agent line to use? So each patient essentially serves as their own study, right? Like sort of like a phase 0 study. And then the other rationale for using neoadjuvant chemotherapy, even though you're going to do surgery, is that remember, these patients are at high risk for pulmonary metastases. I've had patients die because of metastatic disease. And the fastest way to treat this patient and reduce the risk of metastatic spread is that you can start chemotherapy the day after you see him in clinic while you plan for a big operation. Now, in terms of the chemotherapy agents that we use, this data is not unique to MD Anderson. This is really, again, from the orthopedic and musculoskeletal oncology literature. We tend to treat these like Ewing sarcoma patients. So the chemotherapy lines that are used here are from the Ewing sarcomas protocol. And in this particular patient, what we did is we gave 3 cycles of vincristine, doxorubicin, and fosfamide, re-imaged the patient, and coordinated surgery with that 3rd cycle. Next slide, please. Now, in terms of the goals of surgery, this is where histology plays a role also. Now, what we know about bone sarcomas in general really comes from the orthopedic literature, where the gold standard is for an en-bloc resection. And if you live in the spinal oncology realm, this is where we talk about an Enneking resection, an Enneking appropriate versus Enneking inappropriate resection. Now, how do you define that in the skull base? As you mentioned, getting an en-bloc resection here is challenging because of the proximity to the carotid artery and so forth. So the way that we tend to view these higher grade bony sarcomas is the goal of surgery is an anatomic resection of each compartment of the tumor. And so for a bony sarcoma, that means drilling out the invaded area of the bony skull base in an anatomic fashion. So not simply just doing an intralesional curettage. So what I look for are anatomic landmarks that I'm going to skeletonize to indicate that I've drilled everything in a systematic fashion. After dealing with the bony compartment of the tumor, then you secondarily deal with the tumor extensions into adjacent soft tissue compartments and then get soft tissue margins in each one of those compartments. Now, in the sarcoma literature, the way they define extent of resection is an R0 is sort of the gold standard, anatomic resection with negative margins. R1 is basically a gross total resection with no radiographic disease, but you're unclear about the microscopic margins in the soft tissue compartments. And then R2 is, a subtotal resection where clearly the MRI scan shows residual disease. And when we looked at our own experience, we lumped R0 and R1 for the mesenchymal and dedifferentiated chondrosarcomas, and there's a clear difference in tumor control rates. As we've looked at our experience, as we've treated more and more high-grade chondrosarcomas, there is a difference between an R0 and R1. So the goal of surgery here is to hit the home run. So a gross total resection with negative margins with an anatomic resection of any invaded bone. So in terms of selecting a surgical strategy, certainly when I was going through neurosurgery residency, it was hard to figure out how do you get to the infratemporal fossa and how do you define the anterolateral skull base, right? Now, in terms of defining the anterolateral skull base, the way I could think about it, it goes from the orbit to the external auditory canal and includes the infratemporal fossa and the subcranial space. And I think Dr. Fliss is going to cover the anatomy of the infratemporal fossa a little bit later on, but the boundaries of the infratemporal fossa, the anterior boundary is, you can view that as the back wall of the maxillary sinus and the pterygopalatine fossa. The roof of the infratemporal fossa is the middle cranial fossa. The back wall is the ventral surface of the temporal bone along with the stylopharyngeal fascia. The medial wall is the lateral pterygoid plate. And then the lateral wall is the mandible, and the floor you can view as sort of the attachment of the pterygoid muscles to the mandible. And there's no shortage of approaches that have been reported for the management of anterolateral skull base and infratemporal fossa pathology. And in my own practice, I've used these approaches religiously. And so this is an area where you can't be too dogmatic about it. So how did I think about, selecting the approach? Because they each have their own advantages and disadvantages. Do you mind going to the next slide, please? So first of all is the diagnosis, right? So, approaching a bony sarcoma versus a skin cancer versus a parotid malignancy with perineural invasion, very different surgical strategies. So if you know the enemy that you're dealing with and the epicenter of that disease process, that'll take you to what approach to use. So this, as you indicated, is arising from the glenoid fossa. And for a bony sarcoma, what I look at is the extent of bony involvement. What does my bony resection have to consist of? And so you pointed out that this goes up to the cochlea, but doesn't involve it. So it involves the lateral temporal bone structure. So in my mind, I was thinking this is going to need a lateral temporal bone resection to clear the back end of that bony disease. Now, it goes up to the carotid canal along the horizontal and vertical Peter segments, and that's what the arrow on the left and the circle on the right shows. And so in my mind, an anatomic boundary is that I want to see the carotid artery skeletonized at the end of that resection, so I know that I've completed that bony portion of the resection. Then I look at, Then I look at the patterns of soft tissue extension. So intracranially, dura, some subdural disease involvement, in this case, no cavernous sinus involvement. Then here, of course, is involvement of the infratemporal fossa, the main belly of the temporalis muscle, maybe the parotid, but it really wasn't when we looked on the other scans. And here, the pterygopalatine fossa is displaced anteriorly. A clue to that is that the patient doesn't have a V2 neuropathy. So you know that that compartment's safe, but a little concern there when I was looking at it. And then the question with these cases, is there a disease involvement of the parapharyngeal space? And what I usually look at on the MRI scan, is there disease extending behind the stylopharyngeal fascia inferiorly? And the stylopharyngeal fascia is this fascial barrier that extends from the styloid process medially. And the reason why that's a good barrier to know, even if you're a neurosurgeon, is that what sits behind that is the parapharyngeal ICA and the lower cranial nerves. And so on the MRI scan, I didn't see that. And preoperatively, the clinical exam was a clue that the patient didn't have any lower cranial nerve deficits. So we know that the parapharyngeal space is safe and that everything's going to be in the pre-styloid compartment with regards to resection. So for something lateral like this, and for a malignancy, while I'm a big fan of multi-directional cases and I do use them, if you can use one approach to get everything out, then that's the most efficient way. And so in this case, I selected a subtemporal infratemporal fossa approach, modifying various aspects of it. Next slide, please. If you click twice, and again. So certainly, you'd be doing this case with a head and neck surgeon, and head and neck surgeons are great in terms of thinking about airways. As a neurosurgeon, there are certain things that you have to tune your mind into, because while surgery has evolved so much for anterolateral skull-based pathology, what has also improved outcomes is the perioperative management. And so there are a lot of pitfalls with an operation like this that if you plan ahead of time, then you're setting the patient up for a quick recovery and to be able to start chemoradiation as soon as possible. So a key thing here is airway management, right? You have a patient with trismus. Now the pictures here aren't from this specific patient, but you'll see some of these patients that can barely open their mouth. And so the question is, how are you going to intubate this patient, all right? And so what our head and neck anesthesiologists do is they do a fiber optic retromolar intubation to establish that airway. And you have to be thinking about this preoperatively because you want to give your anesthesiologist a heads up. Otherwise, the morning of surgery, there's going to be a lot of confusion about what to do with this patient. In terms of a tracheostomy, given that there's no disease involvement of the oropharynx here, we did not do an elective tracheostomy, but you sort of want to keep that in mind if that's needed. If you click to the next slide, please. So in terms of the approach and what I did here is basically based on the subtemporal infratemporal fossa approach. Now, this was initially described as a pre-auricular approach, all right? But in this case, because of the degree of temporal bone involvement, while we did a pre-auricular incision, we sort of converted it into a retroauricular approach. And what's great is that depending on what pathology you're dealing with, if you know this approach, you can modify it. And the way to view conceptually the flow of this operation, right? Because there are a lot of moving parts to this, and you do this with the head and neck surgeon, and you do this with neurotologists. When you're planning this operation, the flow of the operation is such as that you begin by isolating the great vessels, proximal control of the neck, releasing the floor of the infratemporal fossa. Next, the next portion of the operation is aimed at dealing with the bony portion of the disease. So doing a lateral temporal bone resection in this case, and then a middle fossa resection. And by clearing the bony portion of the disease, you've cleared the back wall of the infratemporal fossa, you've cleared the roof of the infratemporal fossa. And then through that middle cranial fossa defect, you can then dissect along the medial and anterior aspect of the infratemporal fossa and clear it. Because that anatomic compartment is rich with vascular supply and it has a lot of structures. And so you want to find relatively avascular planes to deal with that compartment as a whole, as opposed to doing an intralesional resection and causing a lot of blood loss during the course of surgery. And then soft tissue reconstruction, of course, is an important consideration because you're left with a large defect that's visible to the patient, and there are numerous goals to reconstruction here beyond a CSF leak. So I'll sort of take you through some of the steps here. Now, I'll say that some of the images in the videos are not exactly from this patient. It's just they were most representative of the steps I wanted to highlight. So next slide, please. So in terms of positioning, basically put a shoulder bump underneath the ipsilateral shoulder. For most of these cases, I like to pin. I don't necessarily use navigation for these cases. These are anatomic resections. The head's rotated toward the contralateral shoulder about 60 degrees with the vertex drops towards the floor. Basically like to have the glenoid fossa as the highest point in the field. And that's a nice neutral position so that the head and neck surgeon can do their portion, the neurotologist can do their portion, and the neurosurgeon can do their portion. In terms of monitoring, we do facial nerve monitoring. Now in this particular case, we did not have to mobilize a facial nerve. In terms of when we think about mobilizing the facial nerve is basically if we have to expose the jugular foramen or if the parotid gland is involved. In this case, neither was the case, and so we left the facial nerve in its place, but we exposed it as an anatomic landmark. And then for the reconstruction, the right leg is prepped for an anterolateral thigh flap. Next slide. So in terms of the incision, the way to view this, if you're a neurosurgeon, is that the superior portion of the incision is something that you'd use for an orbital-zygomatic or subtemporal, and that's tailored based on the temporal and frontal exposure that you need. The inferior portion is something similar to what the head and neck surgeons may use for a parotidectomy and allows for a neck dissection. And while that incision is taken right in front of the tragus, essentially the ear canal is sacrificed and margins are taken along the ear canal, and that ear is then flipped back to provide temporal bone exposure. Now, in terms of the neck dissection, what are the objectives of each step? So first of all, for proximal control, to identify the internal carotid artery, to identify the IJ and the lower cranial nerves, just in case you have to do a parapharyngeal space dissection. And then for identification of the external carotid artery, because you can ligate some of those distal branches to help devascularize those anatomic compartments that need to be resected, but also the plastic surgeon is going to need a donor vessel for the free flap. And so you want to expose that for them. Next slide, please. So in terms of the degree of temporal bone resection that's needed, right? While this is arising from the glenoid fossa, the CT scan that we showed you earlier on indicated that there's involvement that goes right up to the anterior wall of the ear canal and involvement of lateral temporal bone structures, but the cochlea and the semicircular canals were not involved. And so the way we think about the degree of temporal bone resection needed for malignancy is whether it's a lateral temporal bone resection, so everything lateral to the inner ear structures, or do you need a subtotal temporal bone resection, involved resection of the inner ear structures, or a total temporal bone resection where the petrous apex is included. And in this case, we did a lateral temporal bone resection. And so the image on the right is actually from this patient. And so the goal here is that all the bone lateral to the semicircular canals, lateral to the facial nerve, up to the tegmen and lateral to the venous system is taken. And that clears sort of the bony disease behind the glenoid fossa. And the other advantage of this is that you can identify a short segment of the vertical segment of the petrous carotid artery, which ultimately you're going to skeletonize via the middle fossa approach. Next slide, please. So the next step here is really the glenoid fossa resection. So you begin to continue anteriorly. And here, essentially, what you want to do with your epidural dissection is identify Glasscock's triangle, Kawasi's triangle, the anterolateral and anteromedial triangle. So, identifying the petrous apex, exposing GSPN, doing that intradural dissection along V3 to bring that dura propria back. And that enhances your exposure of the subtemporal dura and enhances your exposure of the middle fossa. And then at this point, you've got the boundaries of Glasscock's triangle. And the reason why that's an important boundary to know is that the vertical petrous carotid artery sits in that space and just medial to the temporomandibular joint. At that point, once you have the anatomy laid out very efficiently, you can cut out the temporomandibular joint. So I skeletonized V3 going to the infratemporal fossa, taking that cut with the drill bit just anterior to the TMJ. The next step is that medial cut along the TMJ, which is just lateral to the vertical petrous ICA. And so again, knowing Glasscock's triangle helps you stay just lateral to that space. And then posteriorly, because of the lateral temporal bone resection, you know where the geniculate ganglion is and the facial nerve. And so all that bone lateral can very quickly be taken out to clear that portion of the middle fossa resection.
And when you say take, Shaan, when you say take, you're not on block here. You're drilling it out.
Just drilling it out, yeah. And then here, basically separating the joint from the mandibular condyle and is cutting that cartilage. And then, as I mentioned earlier, you want to see the carotid artery at the end of the exposure. And so the goal at this point of the operation now is to skeletonize the horizontal and vertical segments of the carotid artery. And so this, of course, requires transecting tensor tympani and the bony eustachian tube to do that. And the goal of the degree to which you want to skeletonize the carotid artery is, of course, you want good proximal and distal control, depending on how much dissection you can do along the adventitia of the ICA. And ideally, you want about 270 degrees of access to the ICA so that you have good anterior and posterior exposure of the ICA and that you're not working through a narrow corridor along the lateral aspect of the ICA here. And again, having the TMJ out of the way and knowing the boundaries of the different triangles makes this part of the dissection much faster. And that reddish tumor, soft tissue in front of the drill bit was part of this chondrosarcoma extending through the carotid canal there. And usually with these bony sarcomas, can you go back one slide, please?
Sorry,
No
back one slide.
If you go back to the video, and if you just go to the end of the video. Yeah, there you go. So basically, this is where you sort of consider this part of the bony resection completed, is that the ICA is skeletonized, you've got V3 at the anterior part of the exposure, and inferiorly there, I've highlighted the stylopharyngeal fascia, and that's, again, that nice sort of structure you want to see at the end of this portion of the resection, because you know that you have an anatomic boundary then that will facilitate the infratemporal fossa resection, and also you know that you're safe, everything anterior to this posterior as we start dealing with the lower cranial nerves. Next slide. So the next portion of the bony resection is to skeletonize V2, V3 in the anterolateral triangle. And then after doing that and completing the bony resection, then at that point I deal with the soft tissue component of the disease. And so here there was a disease extending through the dura and a little bit into the subdural space here. And you can see the ganglion exposed, and the value of doing a good intradural dissection here is that you really expose that subtemporal dura and have good exposure to that space. And with these chondrosarcomas, usually there's just direct invasion into the dura, but you have to be careful that sometimes they can spread out between the two layers of the dura. So sometimes you're surprised when you resect the gross disease, there may be additional microscopic disease that extends out circumferentially. And so at this point, margins are taken. Now, in terms of resecting dura on the anterolateral skull base, unlike the anterior skull base where you can get wide dural margins, and the only limitation is really the optic canals posteriorly, in the anterolateral skull base and with some of these infratemporal fossa malignancies, you have to keep in mind the venous drainage of the temporal lobe. And that's why in some of these cases, I do get a preoperative venogram, because you want to know, first of all, where vena labe is plugging in into the transverse sigmoid sinus junction, and is there dural disease extending up to that venous junction? Or, for example, is the venous drainage sort of down through into the pterygoid venous plexus? And usually with the first time operation is not a big deal, but with the reoperation where some of those venous drainage pathways may have been previously taken, the last thing you want to do is take away the drainage for an isolated temporal lobe. And again, that used to be a source of morbidity with some of these anterolateral and lateral skull-based resections. So at this point, then the bony resection has been done, the dural and intracranial disease resection is done, and then the last portion is basically dealing with the infratemporal fossa. Next slide, please. And so at this point, you have the back wall of the infratemporal fossa dissected out with the lateral temporal bone resection and exposure to the stylopharyngeal fascia. You have the roof dissected out because of the bony middle fossa resection. So at this point, then you want to dissect the medial aspect of the ITF and then the anterior aspect of the tumor against the pterygopalatine fossa. And in this patient, they had a profound V3 neuropathy, and there's perineural invasion. And so if you click next. Yeah. So V3 is then divided, a margin's taken at V3. And then if you click next, what that provides you access to is then, if you go back one, please. Yeah. So what this allows you then is to dissect the superior head of lateral pterygoid muscle and the inferior head from lateral pterygoid muscle from their bony attachments. And then you get a complete view of the lateral pterygoid plate. And then because you skeletonized V2 with your middle fossa resection, you know where the pterygopalatine fossa contents are. And that anterior aspect of the tumor against the PPF, you have clear visualization from above, and you can clear that. Next. And so this is the view that you get after you've cleared out the infratemporal fossa. On the left is a view from above looking at the anterior aspect of the infratemporal fossa. You can see the superior orbital fissure skeletonized, V2 skeletonized through foramen rotundum going into the PPF, and the contents of the ITF cleared out. On the right is a view of the posterior aspect of the infratemporal fossa from an anterolateral view. And the forceps are on the junction of the horizontal vertical ICA. You see the arrow there. You see there's that thin sort of fascia where the stylopharyngeal fascia is marked. If you click next. Then, when you drill out the pterygoid plates, of course, you have an opening to the sphenoid sinus. You want to acknowledge that. And then you've got the eustachian tube where, it's a nice, again, anatomic boundary. And when the posterior division of V3 dumps down into the infratemporal fossa, it runs right in front of the eustachian tube. And it's important to recognize whether you've, intentionally or unintentionally have gotten into the eustachian tube, because that can be a potential postoperative complication waiting to happen. And so usually what I do is if I have opened up the eustachian tube, I take a little temporalis muscle, a little Surgicel, plug up the orifice, and I suture it closed, so that even if you didn't resect the dura and you're not worried about a CSF leak, you don't want to deal with the seroma draining down to the nasopharynx, and you don't want to deal with the phone calls about that either. Next, please. So what about the reconstruction, right? So, the way we think about skull-based reconstruction in general, you've got, local pedicle flaps, you've got free tissue transfer, you've got fat graft, right? And certainly when you look up middle fossa reconstruction, people have talked about using fat graft and temporalis muscle flaps, right, to reconstruct these defects. Now, this is a high volume defect, right? And the image on the left is from a glenoid fossa resection where the neck's exposed, you see the retractor on the parotid gland, but you've got the subtemporal space resected, the infratemporal fossa resected. a whimsical temporalis muscle flap's not going to fix that defect. The goals of reconstruction here are not only to prevent a CSF leak, but you want vascularized coverage to avoid issues such as osteoradionecrosis or carotid blowout syndrome, because these patients go on to heavy adjuvant therapy. And you want this patient to cosmetically look okay after surgery and heal up so that they can start chemoradiation therapy within 6 weeks after surgery. So this is where we use an anterolateral thigh flap. This is a nice robust flap that the plastic surgeons can harvest simultaneously while you're doing the resection. Now, even if you're not going to do the reconstruction, as a surgeon, you want to know, what do you need to tell the plastic surgeons about before you drop the mic and walk out for dinner at the end of the day? And so usually the things that I communicate to them about is, first of all, areas of dural coverage. So if I've resected the dura and I've done a duroplasty, you want to make sure the free flap is up against that dural reconstruction. You also want to show them where you've skeletonized a carotid artery so that they can cover that to prevent postoperative issues. And then you want to point out where you've got into the sinuses, the oropharynx, if you've got a skin defect. And then with these cancer cases where the facial nerve has been taken intentionally for margins, then the discussion about static versus dynamic options. And in this case, that wasn't an issue. Next, please. So in terms of key steps, there are a lot of moving parts to this operation, but this is a nice versatile approach. Ultimately, you're dealing with a bad problem here. And so you need the appropriate operation to hit the home run for this patient. And, this operation, why it's great is that it can be tailored to whether you're dealing with the bony sarcoma, where the bone needs to be resected and the infratemporal fossa needs to be resected, or are you dealing with, for example, a skin cancer with direct invasion into the skull base? Next slide. So this is the postoperative outcome. What's more important than the imaging is that the final soft tissue margins were negative. And then the other bit of information we look for on histology, in addition to margins, is the necrosis rate in response to neoadjuvant chemotherapy. And a response rate of greater than 90% or necrosis rate of greater than 90% means that that chemotherapy agent is considered to be effective, and we go on to use that in the adjuvant setting. Next slide, please. So in terms of their postoperative course here, patient had a preoperative V3 neuropathy, same afterwards. We caused a marginal mandibular nerve weakness that was temporary, but got better about 3 months after surgery. And of course, with the lateral temporal bone resection, we caused a conductive hearing loss. As part of hearing rehabilitation, a BAHA, bone-anchored hearing aid, was placed at the time of surgery. And the patient was discharged home post-operative day 6, and then started adjuvant therapy, the same chemotherapy line, and proton therapy 5 weeks post-operatively. And this patient now, I think, is about 3 years out from treatment and no evidence of disease.
Speaking with your chemo, how much time did you wait between the pre-treatment chemo to surgery?
Yeah, so basically, usually they nadir, their counts nadir about a week after they're getting chemo. So about 2 weeks after finishing chemo, they're getting surgery. So we're not waiting much time at all.
All right.
So
I think we need to move, Shaan, that was a masterpiece, but I got to give Dan the full
yeah, absolutely,
that he deserves here. So yeah, I'm going to reserve my own comments about your case until then too. But that was great. I'm going to talk about it after. Let's go ahead, and I'm going to go stop sharing my screen, and Professor Fliss, please share yours so that we can hear your wisdom.
Okay, so first of all, thank you very much for the invitation. It's a great honor and pleasure for me being with you guys. Thank you, Walter, for inviting me. Shaan, that was really a very, very nice and interesting presentation. And Todd, I must tell you, did very well. So with that saying, I would like to present my series of the infratemporal fossa approach. During the last around 20 years. And most of the operations that you will see here or the discussions were done at Tel Aviv Medical Center. So just a little bit of anatomy as we've seen before. This is the infratemporal fossa with the anteriorly, the boundary goes to the posterior maxillary wall and the pterygopalatine fossa, medially to the lateral pterygoid plate, as you can see here. Laterally is the zygoma, the temporomandibular joint, and the mandible. And the roof of the whole thing is bounded by the greater wing of the sphenoid. Of course, the temporal bone, as we've seen here, and all this skull base foramina, ovale rotundum, and spinosum. We must understand that most of the lesions that involve the infratemporal fossa do not arise primarily in the infratemporal fossa, but there is a continuity with other craniofacial spaces, like the pterygopalatine fossa, and that means with all the tumors arising in the paranasal sinuses and the nasopharynx. As we've seen from Shaan's presentation, it is in direct contact with the parapharynx inferiorly, with the temporal fossa superiorly, and of course the middle fossa superiorly and above. These are very nice dissections by the late Albert Rotton from my atlas, and it shows you again the relation, the bony relation that we talked about before, and then the soft tissue and the bony relation of the infratemporal fossa. We see here the pterygoid muscles that bound the plexus and the anterior and maxillary artery into the pterygopalatine fossa right here, and V2, V3, and the relation of the infratemporal fossa with the maxillary sinus, with the sphenoid sinus, and with the cavernous sinus right here. This is another dissection by Rotton, and it shows you the relationship with the maxillary sinus, because most of the anterior approaches to the infratemporal fossa went through the maxillary sinus. Again, the pterygoid plexus, the pterygoid muscles, the internal maxillary artery, and when you take off the anterior and the lateral wall of the maxillary sinus, you see the relation between the posterior wall of the maxillary sinus and the infratemporal fossa. I use this usually in order to perform biopsies in the infratemporal fossa through the maxillary transnasally endoscopically, and it's quite a nice way to do this. Again, here you see the pterygoid and the medial and the lateral pterygoid, which actually wrap the infratemporal fossa content. You see the internal maxillary artery and all the relation again with the clivus, with the sphenoid sinus, middle fossa, and V2 and V3. Another interesting work which has been done just before Professor Rotton passed away is to find a way, a corridor through which we can approach the infratemporal fossa endoscopically, transnasally, and as you can see here, the vicinity of the Eustachian tube, as mentioned before, to the infratemporal fossa, medial pterygoid plate, and you see here the levator veli palatini. So the pathology, as I said before, might be primary or secondary. Secondary are by far the most common in this anatomical location. If we're talking about primary lesions, then sarcoma is the most common, followed by schwannoma, which can arise from V2, V3, and then minor salivary gland tumors. There is always lymphoma in the head neck somehow, and this vascular lesion called hemangiopericytoma. Secondary lesions arise from the pterygopalatine fossa, usually angiofibroma, but also lesions that involve the paranasal sinuses, maxillary sinus, and the nasopharynx, inverted papilloma, nasopharyngeal carcinoma, minor salivary glands from the nasopharynx, of course, squamous cell carcinoma, and again, minor salivary glands, adenoid carcinoma. In Europe, this is the most common major salivary gland tumor. From the parapharynx, we have the schwannoma, neurofibroma, paraganglioma, and very rarely pleomorphic adenoma rising in the deep lobe of the parotid gland, and from the middle fossa, meningiomas and chordomas. The diagnosis is often delayed, it's difficult, and this is because the area is inaccessible for clinical and endoscopic exam. They say, according to the literature, that a tumor should be around 2.5 centimeters and even more in order to become clinically evident. The symptoms are insidious, usually loss of function or diminishment of function, as we've heard before, anesthesia, hypoesthesia of V2, V3, V1, then facial swelling, facial pain, trismus, if it reaches the, if it infiltrates the pterygoid muscles. Imaging is very important. I usually do CT and MRI in every case. You can also do CTA and an MRA if you're interested in the vasculature of these lesions. CT can show you the bone destruction at the skull base or other bony structure of the craniofacial skeleton. The MRI with a high soft tissue resolution can show you invasion of the tumor into the brain, muscles, and the eye. And if you get lucky, you can see sometimes some perineural invasion. PET-CT, as we've heard before, is important, especially in cases of malignant lesions. And FNA or FNB, as we've seen before, can be guided by CT. Sometimes when the diagnosis is quite difficult, we would perform an open biopsy, and especially in cases of sarcoma, when the diagnosis is not very easy, and we go through a endonasal endoscopic approach through the posterior wall of the maxillary sinus. These are a lot of surgical approaches. You should bear in mind that 45 years ago, these tumors were not approachable at all. Nobody did operate on these tumors. So during the years, this is from the 60s, the 70s, Conley, Barbosa, then the group from Pittsburgh proposed this facial translocation, subtemporal, preauricular approaches, but most of them are combinations or modifications of the infratemporal fossa approach by Hugo Fisch from Switzerland. Lately, we have the possibility to work with endoscopes or to perform an endoscopic assisted kind of surgery. Most of these approaches will have many limitations. If we talk about the lateral approaches, then facial nerve injuries, trismus, CSF leak, and first bite syndrome, and seroma and wound infection. If we talk about the anterior approaches, then we will have facial swelling and problems with the teeth like paresthesia, pain, facial numbness, nasal crusting, and so on. Looking at the literature, we see that the literature is quite poor in series regarding the infratemporal fossa. Most of the series deal with malignant tumors. Most of the series have a high rate of complications and the recurrence rate that goes from 14 to 60%, with a 5-year survival around 50%. There is only one endoscopic series by Professor Castelnuovo from Milano, but this, in his series, he had only 1/3 of the patients would have malignancy, and all of these were nasopharyngeal carcinomas. The rest of them were angiofibromas. He didn't have any recurrence rate, of course. So these are the skin incisions that I use for preauricular incisions, question mark incision, or we can do a drop into the neck, depending on the size and the location of the tumor. And if you want to do a neck dissection or to control the big vessels and the nerves at the level of the neck before you start the infratemporal fossa approach. I use a Doppler mostly because of the superficial temporal artery if I want to keep the temporal parietal fascia, or if I want to hook a free flap at the end of the operation. This is quite important. And I use a nerve detector during the operation for the orbital zygomatic branch of the facial nerve. And here it is, the temporal parietal fascia, which I use quite often if I don't use a free flap. And I can also use a reverse temporalis flap based on the deep internal maxillary artery in order to reconstruct the defect. This is the elevation of the temporalis muscle from the temporalis fossa. You see here the zygomatic bone. So everything should be free here from the root of the zygomatic bone to the lateral wall of the orbit, because the next step will be to make an osteotomy, which includes the zygomatic and the lateral wall of the orbit, an orbital zygomatic osteotomy, as depicted here. The osteotomy sites should be at the root of the zygoma in order to get more access into the infratemporal fossa, and also on the lateral wall of the orbit, lateral superior wall of the orbit, and the malar eminence here. And this is from Paul Donald's book, which he published some 20 years ago. The pterional craniotomy can be a classical one. As you can see here, this is after the resection of a tumor involving the temporalis muscle. You can see the very nice view into the infratemporal fossa, or you can incorporate also a superior orbital rim and wall of the orbit. So you get a much nicer approach into this area here. You see the temporalis muscle here, which is reflected downwards. And you see here the plating, which has been adjusted just before the osteotomy. And then when we put back the bony fragment, it'll come into this anatomical, preoperative anatomical location. Reconstruction is quite simple. Again, a case in which the temporalis muscle has been resected. You can see here the plating of the orbital zygomatic bony segment here. And you can use craniofix or plating covered with the pericranium in order to avoid postoperative post-radiation osteoradionecrosis. Reconstruction of the temporal fossa when we resect the muscle can be done with this kind of mesh and fat behind, or with custom-made, preoperatively custom-made protheses that we use lately because we can print them in our department. Combined approaches, as mentioned before, you can do a lateral approach, infratemporal fossa approach, and an anterior approach. Usually these approaches, these anterior approaches were craniofacial resections, but you can do the same with a mid-facial degloving technique. It's like in this case here, of a huge angiofibroma involving the middle fossa. So you can do this infratemporal fossa approach in order to control the lesion from above. And you can see here the pterygomaxillary area with the angiofibroma. And so you can control the tumor from below and from above by combining these two approaches. Or in this case here, of a lateral compartment squamous cell carcinoma of the skin involving the infratemporal fossa, but also the mandible here, the glenoid fossa with metastasis at the neck and around the orbit right here. So this can be combined with various anterior and lateral approaches. And there's one case of a 5-year-old girl with rhabdomyosarcoma. She underwent chemoradiation prior to her surgery, according to the European protocol. Again, elevation of the flap, This is temporal parietal fascia that has been used later on in order to feel the defect. Reverse temporalis muscle. And here are the osteotomy lines. As I said before, the tumor here involves the temporalis muscle. So the temporalis, the zygomatic arch has been taken together with the tumor. Look at the beautiful view that you can have into the infratemporal fossa if you do this kind of approach. And here is the the specimen with the temporalis muscle and the tumor, zygoma and malar eminence right here, and the coronoid process had to been taken out also in order to avoid trismus after the radiation. And this is the result, quite a pleasing cosmetic result, no facial nerve paralysis. You still have this depression here. We plan to reconstruct this at a later stage. Just a few words about surgical models, which we use lately for training, education, and especially for surgical planning. These are some of the examples. We'll talk about this one later on. This is a parapharyngeal space tumor, and this is a infratemporal fossa and parapharyngeal sarcoma, which has been already operated in another institution. This is a pterygopalatine fossa tumor. So this is a 66-year-old male with synovial sarcoma involving the temporalis, the infratemporal fossa, and the orbit, as can be seen here. And this is the model involving, see that the tumor here into the model. By the way, we print them in our department, involving the orbit, the temporal, the infratemporal, and the pterygopalatine fossa. This is during the operation, elevation of the muscle. We used a combined anterior and lateral approach in this case. So this is a classical, actually, craniofacial resection and with a Weber-Ferguson, as you can see here. So we have control of the tumor from below and from above. And this is the specimen, a en bloc specimen with the temporalis muscle here, the orbit, the zygoma and the malar eminence, the coronoid process here, and all the pterygomaxillary content. And if you compare this to the model, it's quite nice to have this preoperatively and discuss it with the fellows and the residents, and to plan your dissection. So finally, we came to the series, 52 cases, male to female 3 to 2, around 50 years old, the mean age of these patients. In this series, we followed them for about 34 months, 3 years more or less. About 60% of the cases had prior treatment in another institution before they were sent to us. Altogether, the mean hospitalization time in this series was 11.7 days. Around 80% of the tumors were malignant, with sarcoma, of course, being the most frequent, and then followed by squamous cell carcinoma of the skin. We have this a lot here in Israel, just like in Australia. Squamous cell carcinoma is followed by adenoid cystic carcinoma. Benign tumors accounted for about 21%, the most common of which were angiofibroma and schwannoma from the trigeminus. The tumor size was 4 centimeters. As I mentioned before, these are voluminous tumors. But we received positive margins in 27% of the cases. The site of extension of the tumor was into the paranasal sinuses in about 27 cases, followed by the orbit, nasopharynx, parapharynx, and then clivus, anterior skull base, and only one case had involvement of the cavernous sinus. surgical approaches, the majority preauricular orbitozygomatic, as I showed you before, but also craniofacial resection when we performed a maxillectomy in order to reach this area because the maxilla was involved, and a combined approach of orbitozygomatic and craniofacial resection. That means two compartments, an anterior and lateral compartment approach in 13% of the cases. Around 10% was approached through the endoscope, in a combined open and endoscopic approach in 4%, and endoscopically purely in 6% of the cases. Reconstruction, and this is a big change with the advent of free tissue transfer. We could really reconstruct these defects at the skull base, as we've heard before. We used to use the rectus abdominis muscle at the beginning of the series, but now we use mostly anterior lateral thigh, as you can see here, in 22% of the cases. Pedicle temporalis muscle flap, rotation in 70%, and all the others in about 34 cases. Adjuvant treatment, 60% of the patients, radiotherapy in 30%, chemoradiation 17%, and chemotherapy only in 12%. Complications, so we divide this into surgery-related and adjuvant treatment-related. We had 15% major complications surgery-related. Two flaps unfortunately died, so we have to go back and do another one. CSF leak and sleep ventricle syndrome. Adjuvant treatment related, we had one case of blindness. It shouldn't happen, I agree with you, but we had one case of blindness related to radiotherapy and one case of osteoradionecrosis. But most importantly, we did not have any operative mortality in this series. The survival was around 62% at 5 years with a recurrence rate of 30%. So 30% of these tumors recurred. We looked into prognostic factors and tried to compare male to female, age above 60 and below 60, the tumor size above 4 centimeters, below 4 centimeters, margins, positive versus negative, squam versus sarcoma, and those who had complications against those who didn't. But none of this were statistically significant. Small number of cases, of course. We didn't find any difference between the two. So if we had our study that has been published lately in head and neck, you see that most of it, it's just like the other big series coming from big centers, as you can see here. We had only 80% malignant tumors as compared to Bigelow and Henschel, but it's more like the Sloan Kettering series here. 64% complications in our series, 52 recurrence rate of 30% and 5-year survival at the end of 66%. So in conclusion of this series, sarcoma is the most common pathology, followed by squam. Most of the patients received some kind of pre or post-operative treatment. We achieved negative margins only in 73% of the cases. And surgery was quite well tolerated with acceptable complications by our patients. So these patients are suitable for surgical resection. There is an emerging role of endoscopic surgery, which we don't really understand right now, and important factors for the success of the treatment, according to our series, was the patient selection, very interesting, deliberate use of free flaps, and adjuvant treatment. And I thank you for this. This is Tel Aviv Medical Center by the Mediterranean Sea. And I invite you all, when all this crazy thing is gonna stop, and visit us.
Thank you, Professor Fliss, for that wisdom and that amazing series. Let me ask you the first question. What did you think about Shaan's case? Would you have done anything different? Any nuances that you would have done slightly differently?
Well, there are several. First of all, it was very well presented, and I think I wouldn't have done basically something else. The only thing which we don't do is a neoadjuvant chemo. According to the literature, if you look at the literature, this tumor should be treated according to the grading. And so you have grade 1, 2, and 3, and then you have mesenchymal chondrosarcomas, and then you have dedifferentiated sarcomas. The only place where chemo might have some effect is actually mesenchymal sarcoma. Other than that, chemotherapy does not have any survival benefit actually if you treat dedifferentiated sarcomas or conventional sarcomas. So according to the grade,
but Shaan's case was a mesenchymal one, right, Shaan?
Yeah, it was a mesenchymal one.
It was mesenchymal. So actually has a certain role into this. But all the other subtypes, would you treat them with neoadjuvant also?
The conventional subtype we don't treat with neoadjuvant, and then the dedifferentiated ones, I agree with you. They the response rates are not that great. So if it's a borderline unresectable dedifferentiated, then we would try a neoadjuvant to at least downstage it, because 15 to 20% of them still respond. But you're right, it's mainly the mesenchymal ones where we do neoadjuvant.
Okay,
you know, from a neurosurgeon standpoint, and I know a big part of our audience is always neurosurgeons, the infratemporal fossa is always a black box, and it really must not be. It has to be a lot better known to neurosurgical young career neurosurgeons. So about the contents therein, right? So Shaan, you talked about the eustachian tube very detailed. You close it, plug it, make sure it doesn't leak. What about the IMAX? What about the parotid? Okay, and you say the facial nerve was sacrificed. So can you comment about the other contents, whether you took it, not take it? Was it in the way? Was it out of the way?
Sure. So for this case, the facial nerve, we did not sacrifice it.
Oh, you didn't? Okay, sorry.
Yeah. So, you know, the decision about the facial nerve management for a case like this, when you're dealing with a bony sarcoma, is really, do you need to expose the jugular foramen? And then that would be the reason to mobilize the facial nerve as part of the temporal bone approach when you're dealing with the chondrosarcoma. Now, in terms of the contents, right? So when you look at the contents of the infratemporal fossa, you've got the two heads of the lateral pterygoid muscles. You've got the medial pterygoid muscle, which sort of runs along the floor of it. The distal branches of the IMAX, which also supply leads to the detemporal arteries and the sphenopalatine artery. And then you've got the anterior and posterior divisions of V3, right, that have a little bit of a complex branching pattern relative to the lateral pterygoid muscle. So, those are the contents. Now, for a cancer case, the decision is really, are you going to evacuate the entire contents of the pterygoid, the infratemporal fossa, or can you selectively take margins depending on the degree of involvement, right? Because there are some glandoid fossa chondrosarcomas where the mandibular condyle is okay, and the superior head of the lateral pterygoid muscle is not involved, then you're going to leave the infratemporal fossa untouched. So, I think, understanding the anatomic boundaries and how to get around it without causing a lot of blood loss makes it for a very nice dissection in that space. Versus if you're dealing with the trigeminal schwannoma going into the infratemporal fossa and you're doing a subtemporal approach, that's going to create the corridor for you, depending on which division of the trigeminal nerve it's tracking along.
So for your specific case, was IMAX at all an issue?
So IMAX, we sacrificed with the external carotid artery dissection. You just sacrificed that and it wasn't an issue.
Okay.
So that's
what about, so in V3, can you mention specifically what you did with V3?
V3 had divided that.
You divided that. And then was the parotid ever in the, even if you didn't sacrifice the facial nerve, you know, or didn't hurt the facial nerve even, did you have to go through the branches? How did the parotid relate to your field?
Yeah, so when you're, since the mandible is not involved in this case, you know, just a little bit of the condyle was involved. When you look from lateral, the mandibular condyle sits above the parotid gland. And so in this, you can imagine by isolating the floor with the neck dissection, the back end, the roof, you're essentially working medial to the parotid gland, and you never have to deal with it in the way.
Okay.
So sort of working like through a tunnel deep to that space.
Okay.
The only
So go ahead.
because when you elevate the flap, actually.
Exactly.
Yeah.
All right. And we're late. I don't see anything in the Q&A box. One last point I want to make with regard to Todd's answers and whatnot. I think it's very important for young trainees to really think through not just their part. And as Shaan, you mentioned as well, you don't just drop the mic and say, okay, now yours, bye. See ya. You need to plan the whole operation from A to Z, not just to like F. And you need to make sure that the people helping you with the whole case have the whole picture, such that, you know, the plastic surgeons are involved in the get-go and not just come in and say, oh, you created a mess, now you expect me to fix it. That's really not very nice and ultimately not very kind to the patient, because that leads to probably poor outcome. Any final thoughts from the panelists?
What kind of lesion would you consider inoperable in this location?
Relating to like chondrosarcoma, or, you know, I mean, I guess when just in general. So what would be unresectable is one where the carotid's encased. You know, if it's a high-grade malignancy, like a high-grade sarcoma, skin cancer, look at the vascular involvement. So if there's gross disease invading the adventitia, not going to do it. Also, the extent of perineural invasion is a consideration, meaning that when you have perineural invasion along the facial nerve that goes proximal to the geniculate ganglion, you know you're going to have microscopic disease there. And then when there's perineural invasion along the trigeminal nerve that goes to the trigeminal root right in front of the brainstem, you know that there's basically, that's knocking on the front door of the brainstem. So I guess those are the key structures I look at whenever, you know, my head and neck colleagues send me a malignancy and ask me if it's resectable or unresectable. Those are the things I look at in this structure, in this area.
Professor Fliss, do you agree with that encasement of the carotid being non?
I would add the prevertebral fascia if it's on the way.
Yeah.
You know, parapharynx. That's my opinion too. Yeah.
All right, but that generates another question then, Shaan. Why, if the carotid can be bypassed, why? Take it.
Yeah. So I think that's a good question.
Stent, you know, he's got this special stent that he puts into the carotid artery, and then he operates on the stent. Mario Sana from Italy.
So I've done the stent in some cases. I think it depends on the disease process you're dealing with. So, you know, when I showed you, there's a big difference between a gross total resection with negative margins versus gross total resection with even positive margins, right? When you look at high-grade chondrosarcs, high-grade osteosarcomas, versus if you're leaving microscopic diseases behind versus just treating that with chemoradiation therapy, patients tend to do better, you know, with regards to chemoradiation therapy, you know, and have made that mistake early in my career where I took someone for a gross total resection, but leave microscopic disease along the carotid artery. And that patient progressed while waiting for chemoradiation therapy in 3 weeks. I think when there's adventitial involvement, that's a marker of bad disease. When there's invasion of the lower cranial nerves and the parapharyngeal space, that's just biologically a bad actor. And that patient, while you can get a gross total resection, won't even wait to start chemoradiation therapy. Versus a low-grade process like a low-grade chordoma, it's a different thought process. The biology makes a big difference in terms of resectability versus unresectability.
We actually have one question from the audience. Ahmed, you have a hand raised. I'm allowed you to talk. What's your question? Ahmed, are you still there? Okay, it's not. So, but I'll ask the question again, though, Shaan. We're not talking about leaving disease, microscopic disease on the adventitia. If you're carotid encased, why not bypass it and then take that? Any role in bypassing cancer surgery?
No, I think much smarter people have looked at this before.
That's a very clear. That's a very clear answer.
I think much smarter people have looked at this before my time. And when you looked at all those studies in the hands of really good bypass surgeons, right? So it wasn't even a technical issue with the bypass. The outcomes were poor. And it's because it's usually not just involvement of the carotid. There's a lot of other stuff right in front of the carotid, like the lower cranial nerves that are involved or the other nerves, right? So, to think that bypassing that segment of the carotid artery, you're clearing the rest of that disease, I think there's a false sense of security.
Okay, I agree with you, but I just want to push that to make it absolutely clear.
No, it's a good question. I like it.
So again, at this point, then we're running late. Thank you so much for your participation today. That was a tour de force of a discussion because, again, this topic just doesn't come up very often. And for someone like me, who, again, a neurosurgeon who's interested in minimally invasive stuff, this is not a case where you can do minimally invasive anything. I mean, this is go big or go home for sure. You can't, if you start minimally being invasive about cancer, then you're going to just get a recurrence right off the bat. So yeah, thank you for teaching me so much today. Next time, we're going to be back in 2 weeks again, this time with a former president of the NASBS as our honored guest, who is going to be Ian Witterick. And so we're staying in the ENT space, anterior ENT space for a little while. So thank you again. Have a good day, the rest of you. Thank you, Professor Fliss, Todd, and Shaan. And I'll see you at live meetings and see you in 2 weeks. Bye.